we will take up the definition, the etiology, the stages and the clinical features and complications today. Okay. Now, the definition that we discussed on the first day, that is chronic kidney disease, which was previously termed chronic renal failure. It refers to an irreversible deterioration in renal functions. This irreversible is very important, which usually develops over a period of months or years. Okay. Initially, it is manifested only as a biochemical abnormality of the urea, creatinine and other renal parameters, but eventually the loss of excretory, metabolic and the endocrine functions of the kidney leads to a symptom complex and various diverse type of clinical signs. These are altogether termed as uremia. Now, when it is very advanced, when death is imminent without renal replacement therapy, which usually happens when the patient needs the stage 5, then it is called End-Stage Renal Disease or ESRD to be precise, or End-Stage Renal Failure, ESRF. ESRD is the more common term. In most countries all over the world, an estimated prevalence of CKD stage 3 to 5, that is the severe version of the disease, when the eGFR means estimated glomerular filtration rate, it is around 5 to 7%. It mostly affects people above 65 years of age, but the prevalence in patients with diabetes mellitus, hypertension and other vascular diseases is substantially higher, and the prognosis is also worse in these patients. So, in these type of patients, a targeted screening should be done from the very beginning. Just as an example, when you find a type 1 diabetes mellitus or a type 2 diabetes mellitus, in a type 1 diabetes mellitus, it is mandatory that you start screening from the 5th year of diagnosis. And in case of type 2 diabetes mellitus, that we find more often in our vicinity, from the very first encounter with the patient, you have to screen for the presence of diabetic nephropathy or diabetic kidney disease. And it should be repeated ideally every 6 months or at least once in every year, so that a thorough screening for CKD is done in these patients. Now, it is very interesting that a great majority of these chronic kidney disease patients actually never go to stage 5. Why is this? This is still not clear. Lots of research work are going on all over the world, but it is very fortunate that all these patients do not go to stage 5, because the disease burden of CKD is so large in all the communities in all the countries of the world, that if most of these patients would go to stage 5, then it would be devastating for the healthcare system for all over the world, because it is crushing for the family as well as the healthcare system. Healthcare system of no country in the world can afford to give renal replacement therapy to all those stage 5 patients free of cost. No country has that much has got that much of financial power. So, it is very fortunate that all these patients never go to stage 5, only a percentage of the patients goes to stage 5. This we discussed on the first lecture. This is actually not the definition, it is the staging of the chronic kidney disease. It is based on the estimated glomerular filtration rate or eGFR, which corresponds to the creatinine clearance rate. Let us go to the next slide to know how the eGFR is calculated, and then we will come back to this slide again. This is the Cockcroft-Gault formula that we discussed on the first day. It is a handy and easy to measure formula to estimate the eGFR. This is 140 minus age multiplied by the weight of the patient divided by as a whole the serum creatinine multiplied by 72. This formula is for the male patient. For female, you have to multiply this with 0.85. Okay. This is a very handy formula that you can calculate within 30 seconds in your OPD or in your chamber. The more accurate formula, that is called DMRD formula, It's a short form of diet modification in kidney renal diseases, DMRD. This formula is used by the laboratories and other agencies, but that is a more complicated one. You have to employ some log table, etc., to calculate. So, not very handy for us on the day-to-day practice. But when you find a pathology report from a reputed lab, they usually calculate eGFR along with the serum creatinine, etc. They usually calculate it with DMRD formula, but that's not very relevant for us. Based on this eGFR, we stage the CKD patients. Okay. What are the stages? Stage 1 to 5. Stage 1, when eGFR is more than equal to 90 milliliter per minute per 1.73 square meter. Here, there is minimal kidney damage with usually raised glomerular filtration rate. The stage 2 is eGFR 60 to 90, that is 60 to 89. Here also there is kidney damage with a bit more kidney damage with a mild reduction of the GFR. These two stages are not clinically ascertainable. You can diagnose them clinically, not even in a renal biopsy with an ordinary microscope. These can only be diagnosed with electron microscopy. So, these are for research purpose only. You can't clinically diagnose them. It becomes significant when the patient enters the stage 3, which is divided into two parts, 3A and 3B. 3A is when the eGFR comes down from 45, from 60 to 45, that is 45 to 59 to be precise. Here, there is moderate reduction of the glomerular filtration rate, and stage 3B is where it is 30 to 44. You can remember like this: above 90, 60 to 90, 30 to 60, then stage 4, that is 15 to 30, and stage 5 below 15 for remembering. In stage 4, eGFR is 15 to 30 or 15 to 29. Here there is severe reduction of the glomerular filtration rate, and here the clinician has to prepare for kidney failure to manage it properly. And stage 5, that is the most severe stage, when the eGFR is less than 15, it is end-stage kidney disease or kidney failure properly. In this stage, you have to either go for regular hemodialysis or dialysis in any other form, or one has to try renal transplantation. With these 5 stages, you can add 3 letters. When the addition of P to a stage is done, it signifies that there is significant proteinuria of the patient, and this proteinuria is quantified on the basis of a albumin creatinine ratio or ACR. That can be done on the 24-hour urine collection also, or more commonly these days we do it with a spot urine estimation. Stage, when we add a T to the stage, that is stage 40, it indicates that the patient has got a transplanted kidney, and after renal transplant he has developed chronic kidney disease again, chronic renal failure, chronic kidney disease again. And addition of D to the stage indicates that the patient is on dialysis. Obviously, this patient will be on stage 5. So, if we say stage 4D, not 4D, sorry, stage 5D, that means the patient is in stage 5 and he is undergoing dialysis. Now, what are the common causes? This table is taken from a Western textbook, so it does not correspond to the actual scenario of our country. In our country and most of the third world and developing countries, the commonest cause of CKD is diabetes mellitus, diabetic nephropathy. In our country, it is almost 60 to 70%. Almost 60 to 70% of our patients who are undergoing dialysis are accounted for by diabetic nephropathy stage 5. Okay. The next common cause is hypertension. Third common is glomerular diseases, IgA nephropathy and other forms of chronic glomerular nephritis. Then comes renovascular disease, which are mostly atheromatous. and congenital and inherited diseases like polycystic kidney disease, which is quite common in our OPDs. And there is also Alport syndrome, which is congenital chronic glomerulonephritis. The other causes are interstitial diseases, which is quite significant in the Western countries because they are much used to analgesic abuse. In our countries, analgesic abuse is not that much. We take randomly over the counter analgesics, but not chronically like them. So, the chance of analgesic nephropathy is relatively lower in our country till now. Okay. It can also occur due to some other drugs and other toxic chemicals, some obscure Chinese herbal remedies, etc. From some African herbal remedies also they have been documented. There are other causes which are not that common, like HIV nephropathy, like reflux neuropathy, like CKD associated with infiltrative diseases like multiple myeloma, other paraprotein associated chronic kidney diseases and amyloidosis like that. These are relatively rarer you can find. Now, let us come to the clinical features. The typical presentation of a chronic kidney disease at advanced stage of case of chronic kidney disease is raised level of serum urea and creatinine, and this is frequently associated with hypertension, proteinuria or anemia. Now, if we come to the general symptoms, most patients with the slowly progressive disease are actually asymptomatic until the GFR comes below 30 ml per minute per 1.73 square meter, that is when the patient enters stage 4 or stage 5. But there are some patients who can remain asymptomatic with much lower GFR. Only when he has come to you for some other disease and you have done a routine screening, you find that his creatinine level is almost 9 milligram per deciliter or something like that, but the patient has been asymptomatic, was not aware of his disease condition. Nocturia is often an early symptoms, but this is non-specific. This is due to loss of the concentrating ability of the nephron, and there is increased osmotic load per nephron due to more GFR. When the glomerular filtration rate is less than 15 to 20 milliliter per minute per 1.73 square meter, that is stage 5, then symptoms and signs are fairly common, and this can affect almost any system of the body. Typically, there are tiredness or breathlessness, mostly due to renal anemia. I am coming to the causes of renal anemia later. There is anorexia of the patient over the previous 3 or 5 months. There is generalized pruritus. You can find marks of excoriation and itching in the whole body. There is weight loss. There is nausea, vomiting, etc. With further deterioration in renal function, the patient may suffer from hiccups, typical type of deep respiration, which is called Kussmaul's breathing. Once you see it, you will remember for your life. And there are muscular symptoms and signs like muscular twitching, asterixis, fits, drowsiness, and ultimately coma in the unhydrated patient. This is just a pictorial representation of the common symptoms that we find in an advanced case of chronic kidney disease. You can see there is jugulous venous pressure raised caused by the fluid overload or maybe due to pericardial effusion causing pericardial tamponade also. There is pulsus paradoxus, and this is caused by the pericardial tamponade also. You can find a peritoneal catheter implanted in the patient if the patient is already on peritoneal dialysis. There is increased respiratory rate and depth in metabolic acidosis, as I said, Kussmaul's breathing. There is yellow complexion and pallor. A dual lumen central venous catheter for dialysis access in the subclavian or the jugular venous area. You can find a pericardial friction rub here, which is an indication for urgent dialysis. Sign of pericarditis manifested by a pericardial rub, you should always prompt you to go for a prompt dialysis. Transplanted kidney, right or left with overlying scar. If the patient has already been transplanted previously and has developed a CKD again, then you can find a transplanted kidney scar on the right side or the left side. There is brown line pigmentation in the nails. There may be excoriation of pruritus all over the body. Patient may bruise easily because bleeding time is more due to platelet dysfunction. There may be peripheral neuropathy with absent reflexes, reduced sensation, paresthesia, restless leg syndrome, etc. Now let's come to immune dysfunction. In CKD, there is impairment of both cellular and humoral immunity, particularly in the advanced CKD. And this accounts for the increased susceptibility to infections, which is the second commonest cause of death in a patient who is on dialysis. The commonest cause is cardiovascular events, a stroke or heart stroke or brain stroke. But the second commonest cause of death is infections. This usually occurs due to the access devices. Access devices means the catheters, the subclavian or jugular catheter used for dialysis, or the peritoneal catheter or the femoral catheter, these things. These are the commonest cause because these are indwelling things and they predispose you to a significant infection because the patient's immunity is quite low. But there may be some common infections also, like a simple pneumonia. What are the hematological complications? There is increased bleeding tendency of the patient because of platelet dysfunction, manifested by mucosal bleeds and ecchymosis in the skin. The impairment of platelet function and the prolonged bleeding time is usually partially corrected when the patient is undergoing dialysis. Anemia is very common, but in case of chronic kidney disease due to polycystic kidney disease, there may not be significant anemia. This one has to remember. What are the causes of anemia in chronic kidney disease? Because anemia is a very prominent feature in all cases of chronic kidney disease. What are the causes? Main 5 causes are: number 1, deficiency of erythropoietin. Number 2, toxic effects of uremia on the marrow precursor cells. Number 3, there is reduced red cell survival. Whatever RBC is produced, they cannot go to whole lifespan of 120 days, but get destroyed quite earlier. There is increased blood loss due to capillary fragility, poor platelet function and different procedures. You know, there are blood being tested so many times throughout the course, and during every dialysis, during every procedure, there is small amounts of blood loss. So, cumulatively, these lead to a significant blood loss in these patients. That is also a significant cause of anemia in these patients. And there is reduced intake, absorption and utilization of the dietary iron. The intestinal capacity of absorbing the iron gets significantly reduced. So, in these patients, often you have to resort to parenteral iron therapy. You cannot rely on the oral intake only. What are the electrolyte abnormalities? And the fluid retention is disproportionately high in milder disease, and sometimes there is episodic pulmonary edema also. This is mainly in the earlier stages, especially with renal artery stenosis. Some patients who have got tubulointerstitial disease, especially the interstitial nephritis, these patients paradoxically can develop salt wasting disease. Here there is reduction in weight, less and less amount of fluid overload, and there is electrolyte deficiency. In these patients, one has to supplement more sodium compared to the other patients. And acidosis is quite common. It is usually asymptomatic in the initial stages, but in the advanced stages, it may lead to more catabolism, less protein synthesis in the body, may worsen the electrolyte abnormalities, and it may aggravate the myopathy also. Few points about the endocrine function. There is hyperprolactinemia, which leads to hypogonadism and loss of libido in both genders. The half-life of insulin is prolonged due to reduced tubular metabolism. So, there is relatively more insulin available in the circulation which predisposes to an inadvertent hypoglycemic tendency. Also, there is insulin resistance in the tissues. So, this causes an opposite effect. Insulin is there, relatively raised insulin level is there, but that is not working properly at the tissue level. So, opposite thing happens. Again, there is reduced appetite in all of these patients. So, here also the blood sugar level tends to reduce. So, there are conflicting scenarios in related to insulin. So, in advanced cases of CKD, the requirement of insulin becomes very paradoxical. In a stage 2 or stage 3 patients, you can calculate the insulin requirements according to a formula or according to the daily need of the patient. It is relatively easier. But in an advanced CKD patients, the requirement of insulin becomes very erratic. Sometimes you find there is hypoglycemia, sometimes with the same dose you can find that patient is level of blood sugar level is quite high. About the neurological and muscle function, there is general myopathy due to poor nutrition, hyperparathyroidism, vitamin D deficiency and dyselectrolytemia. There is muscle cramps and a peculiar syndrome called restless leg syndrome. What is this? During sleep, there is twitching movements of the legs or jumping movements of the legs. This is called restless leg syndrome. There are sensory and motor neuropathy manifested by paresthesia and foot drops, etc. But these are relatively less common nowadays because of the wider availability of renal replacement therapy. Usually, when there are more and more dialysis done and the effectively renal replacement therapy has been achieved, these neurological complications gradually get reduced and patient almost become normal. These are reversible. Few points about the cardiovascular complications. These patients have almost universally have got hypertension, which is often a refractory hypertension. You may need 3 or 4 antihypertensives in the fullest dose to control that BP. And this is more risky when the patient has gone beyond stage 3 and there is associated proteinuria or microalbuminuria. There is left ventricular hypertrophy secondary to this systemic hypertension. There is associated pericarditis leading to pericardial tamponade and often constrictive pericarditis. When there is pericardial tamponade or a significant pericarditis, this is an urgent indication for dialysis. And the thing is medial vascular calcification, which is due to high serum phosphate levels that occurs beyond stage 3B. This is due to generalized hyperphosphatemia, which gives rise to ectopic calcifications in different parts of the body, particularly in the vessels. This hyperphosphatemia gives rise to raised level of FGF23. This is a hormone, fibroblast growth factors 23. This is also related to the cardiovascular growth factors. ভেসেলের যে তিনটে লেয়ার থাকে ইন্টিমা মিডিয়া আর এক্সটার্নাল দ্যাট মিডিয়াল রিজিয়নটাতে ক্যালসিফিকেশনটা হয় দ্যাট ইজ মিডিয়াল ভাস্কুলারাইজেশন তো দিস সিরাম FGF23 level is associated with increased chances of cardiovascular complications. So, this can also be used as an independent predictor of mortality in chronic kidney disease. That is very important. This is the picture of the renal osteodystrophy, a simplified picture scheme. The interplay between the calcium metabolism, the vitamin D metabolism and the phosphate metabolism in case of chronic kidney disease is very complex. Due to impaired renal function, there is less conversion of 25 hydroxy D3 into 125 dihydroxy D3. So, this is responsible for the calcium absorption in the intestine. So, because of reduced level of 125 dihydroxy D3, there is less calcium absorption. This lead to reduced plasma calcium. This stimulates the parathyroid glands. So, there is more secretion of parathormones. These parathormone reduced to mobilization of calcium from the bones. And there is raised level of phosphates also because of the reduced glomerular filtration. So the phosphate level in the blood also rises. This raised level of phosphate gives rise to increased secretion of FGF23 from the bones. FGF23 increases the excretion of phosphate. Up to a level, up to a threshold, this tries to maintain the phosphate level in the blood. But when this homeostasis fails due to the advancing disease, then the phosphate gets deposited in the blood and the level of phosphate rises. So what we find? That the calcium level of the blood has reduced, but the phosphate level has risen. These two together leads to ectopic calcification in different parts of the body, particularly in the vessels and other places. So you see, there is less phosphate excretion, leading to increased plasma phosphate and the reduced calcium level. This gives rise to ectopic phosphate. Now, the biochemical and the histologic appearance in this renal osteodystrophy may be different types in different scenario. Like in osteitis fibrosa cystica, that is when there is increased level of parathormone leading to mobilization of bone calcium from the bone, there is osteoporosis. But there are some cases where there is ectopic autonomous production of more and more parathormone from the parathyroid glands due to over stimulation of the glands. So these give rise to secondary hyperparathyroidism and ultimately tertiary hyperparathyroidism. Paradoxically, if you overtreat the patient with vitamin D, then calcium mobilization from the bones is less. The bone turnover is much less. That is called adynamic bone disease. Here the mobilization of calcium from the bone is much less than the ordinary level and the parathormone level is high. This is called adynamic bone disease. So these are the pathogenesis of the renal osteodystrophy. It is almost universally associated with all the patients of CKD. Okay, these were the common features and common complications of the chronic kidney disease, and there are particular points regarding the specific causes of CKD that you can ascertain with the particular those cases individually. And any questions from this? কোনো জায়গাটা বুঝতে যদি অসুবিধা হয়ে থাকে বলো। অ্যাডাইনামিক বোন ডিজিজ, যেটা অস্টিয়াইটিস ফাইব্রোসা সিস্টিকা, মানে কি হচ্ছে, যখন ক্যালসিয়াম লেভেল কমছে, প্যারাথাইরয়েডটাকে স্টিমুলেট করছে, প্যারাথর্মন বেশি বেরোচ্ছে, সেই প্যারাথর্মনকে বোন থেকে ক্যালসিয়াম মোবিলাইজ করে দিচ্ছে বেশি বেশি। ঠিক আছে, এটা হচ্ছে অস্টিয়াইটিস ফাইব্রোসা সিস্টিকায় বোন টার্নওভার বেশি বেশি হচ্ছে। কিন্তু যদি আমি ভিটামিন ডি, এটা তো হচ্ছে ভিটামিন ডি ডেফিসিয়েন্সির জন্য, আমি যদি একটোপিক ভিটামিন ডি বেশি বেশি করে দিই, ট্রিটমেন্ট করার সময় ভিটামিন ডি দিয়ে সাপ্লিমেন্টেশন করা হয়। এবার যদি সেটা ওভার এনথুজিয়াস্টিক্যালি বেশি ভিটামিন ডি দেওয়া হয়, তাহলে কি হবে, রিভার্স ব্যাপারটা হবে। তখন বোন টার্নওভার যেটা নর্মালি হচ্ছিল, বোন থেকে যে ক্যালসিয়াম টার্নওভার যেটা নর্মালি হচ্ছিল, সেটুকু আর হবে না। এই বোন টার্নওভার ব্যাপারটাই অনেক কমে যাবে, সেটাকে বলা হয় অ্যাডাইনামিক বোন ডিজিজ। হ্যাঁ বাড়বে, কিন্তু ভিটামিন ডিটা যেহেতু অনেক বেশি থাকবে, সেহেতু আমাদের সিরামের ক্যালসিয়াম লেভেলটা হাই থাকবে। ক্যালসিয়াম লেভেল হাই থাকলে তখন তার মোবিলাইজেশনটা হবে না। প্যারাথাইরয়েড লেভেল যাই হোক, যদি সিরাম ক্যালসিয়াম লেভেলটা হাই থাকে, তাহলে বোন থেকে ক্যালসিয়াম এটা মোবিলাইজেশনটা হবে না। মোস্ট ইম্পর্টেন্ট ক্লিনিক্যালি হচ্ছে অ্যানিমিয়া অ্যান্ড দিস রেনাল অস্টিওডিস্ট্রফি, যেগুলো খুব আউটডোরে, যেগুলো খুব অ্যাডভান্সড সিকেডি পেশেন্ট দেখতে পাবে, স্টেজ 4 নিয়ারিং ডায়ালিসিস বা স্টেজ 5 অলরেডি ডায়ালিসিস শুরু হয়ে গেছে, তাদের দেখবে যে অ্যানিমিয়া, হাইপারটেনশন অ্যান্ড রেনাল অস্টিওডিস্ট্রফি, এই তিনটে জিনিস সবচেয়ে বেশি সিগনিফিক্যান্ট থাকে। হাইপারটেনশন ইজ ভেরি সিভিয়ার, কন্ট্রোল করা যায় না, 4-5টা ব্লাড অ্যান্টিহাইপারটেনসিভ ফুল ডোজে দিয়েও অনেক সময় কন্ট্রোল করা যায় না, ঠিক আছে। রেনাল অ্যানিমিয়া ইজ ভেরি ইম্পর্টেন্ট, প্রায় সব পেশেন্টে থাকে। এদের একই সাথে আয়রন সাপ্লিমেন্টেশন করতে হয়, ওরাল দিতে হবে। অনেক সময় ওরালে সাফিসিয়েন্ট হয় না, তাদের প্যারেন্টালি আয়রন দিতে হয়, এবং তার সাথে এরিথ্রোপয়েটিন সাপ্লিমেন্ট করতে হয়। এখন এরিথ্রোপয়েটিনের চাইতে ডার্বাপয়েটিন ইজ মোর প্রিফার্ড, কারণ এরিথ্রোপয়েটিন সপ্তাহে মিনিমাম 2 বার করে দিতে হয়, অ্যান্ড দ্য ডোজ ইজ কোয়াইট হাই। তার চাইতে ডার্বাপয়েটিন, হুইচ ইজ আ সিনথেটিক ভার্সন অফ এরিথ্রোপয়েটিন, সেটা এখন বেশি দেওয়া, ওটা সপ্তাহে 1 বার দিলে বা লেটার স্টেজে 2 সপ্তাহে 1 বার করে দিলেই হয়ে যায়। এই তিনটে মিলে অ্যানিমিয়াটাকে কন্ট্রোল করে। আর রেনাল অস্টিওডিস্ট্রফির জন্য ইউ হ্যাভ টু জুডিশিয়াসলি এস্টিমেট দিস থিংস, ইউ হ্যাভ টু মেজার দ্য ক্যালসিয়াম, দ্য ফসফেট লেভেল, দ্য প্যারাথার্মন লেভেল। এইগুলো দেখে কোনটা কমছে কোনটা বাড়ছে সেটা বুঝে সেই অনুযায়ী সাপ্লিমেন্ট করতে হবে। আর বেশিরভাগ ক্ষেত্রে এর সাথে তোমাকে ফসফেট বাইন্ডার দিয়ে ফসফেট বার করে দিতে হবে, কারণ যত বেশি ফসফেট জমবে তত রেনাল অস্টিওডিস্ট্রফি বাড়বে, ঠিক আছে। 2 types of phosphate binders are there, calcium based phosphate binders, calcium acetate and calcium citrate, আর নন ক্যালসিয়াম বেসড, ওগুলো হচ্ছে করে চিলেট করে বার করে দেয়। সেভেলামার বলে একটা মলিকুল আছে, এগুলো আফটার দ্য মিলস খেলে যে ফসফেটটা ডায়েটে আসছে সেই ডায়েটটাকে ওই ফসফেটটাকে চিলেট করে স্টুলের সাথে বার করে দেয়। এই দুভাবে ফসফেটটাকে কমানো। তো দিস 3 থিংস আর দ্য মোস্ট ইম্পর্টেন্ট। বাকি যে ব্যাপারগুলো সেগুলো যত সিকেডিকে ভালো তুমি কন্ট্রোল করবে, যত অ্যাডভান্স স্টেজে ওটাকে ঠিকঠাক কন্ট্রোল করে রাখবে, তত বাকি জিনিসগুলো কম থাকবে। কোস্টাল ব্রিদিং কোনোদিনই হবে না যদি সিকেডি মোটামুটি কন্ট্রোলে থাকে, ঠিক আছে। এই যে ইচিং হচ্ছে, ইচিং এর জন্য কি করা হয়, অ্যান্টিপ্রোয়াইটিক মেডিসিনস আর দেয়ার, তার চেয়েও বেশি যেটা লোকাল এফেক্টে বেশি কাজ হয়। পেশেন্টদের নারকেল তেল মাখতে বলা হয়, বিকজ ইট ইজ ভেরি মাইল্ড, চামড়াটা নরম থাকে, এই যে ইচিং বা একটা ইরিটেশন যেটা হয় সেটা আস্তে আস্তে কমে যায়। এইরকমভাবে নানা রকম লোকালি এগুলোকে কন্ট্রোল করা হয়। কিন্তু ওই জিনিসগুলো অ্যানিমিয়া, রেনাল অস্টিওডিস্ট্রফি, হাইপারটেনশন নিডস পলিথেরাপি, আদারওয়াইজ ইউ ক্যান কন্ট্রোল দেম, ঠিক আছে। বলো আর কিছু। নেক্সট ডে আমরা ডায়াগনস্টিক্সে আসবো, ডায়াগনোসিস প্রসিজিয়ার্স, ট্রিটমেন্টটা অনেক বড়, অনেক কিছু ব্যাপার আছে, প্রোফাইল্যাক্সিসে আসবো। আর ডায়াবেটিসে পার্টিকুলারলি, ডায়াবেটিসের সাথে সিকেডির রিলেশনটাকে আরেকটু ডিটেলে পরের দিন আমরা আরো ডিসকাস করবো, ঠিক আছে। তাহলে শেষ করি আজকে, একটু তাড়াতাড়ি শেষ হয়ে গেল। বলো আর কিছু জানার থাকলে বলো।